So we move on to the next case.
Yes, sir. We are now presenting the case.
Here we have a 13-year-old male with the diagnosis of closed distal both bone fracture of the left forearm. He has been posted for closed reduction and pinning, and the case shall proceed under infraclavicular block. But because he is a young, anxious male, he has been well sedated and is under laryngeal mask airway. Over to you, sir.
Welcome, Dr. TVS Gopal.
Morning, Bala. Very good morning to all those seated in the auditorium. As my colleague just announced, he is a 13-year-old boy with fractures in his forearm, which require open fixation. This guy was very tense. When I tried to scan him in the pre-op holding bay, I summed up all my knowledge of Tamil and told him, Vali irukada. And then he gave me a sort of a quizzical look and answered in good English, I don't want injection. So what we did is, we had a discussion, Bala was also there. We decided to put him to sleep. He's got a ProSeal size 3 LMA in place. And so what we will be doing is, we will do the infraclavicular brachial plexus block for intraoperative and postoperative analgesia. I have with me an HFL 38 probe. HFL is high frequency linear, and 38 because the footprint of the probe is 38 millimeters. I've used a biofilm, which is Tegaderm, to cover the patient end of the transducer. And this, as you can see, it fires between 6 to 13 megahertz. So this is a high frequency linear probe. I've used a drape to prep the patient's part. And as you can see, the arm has been abducted. When the arm is abducted, what happens is the clavicle moves. When the arm is abducted, what happens is the clavicle moves superiorly. And when you place the probe in this manner, which is called the parasagittal plane, it offers adequate space between the clavicle and the probe to insert your needle. So I'll just begin by scanning, and I'm just using betadine solution as an acoustic couplant. I'm not using any gel here, because I believe that when you use gel, there is a lot of unintentional probe movement which can sort of distract you when you're doing the block. So I'm just placing this inferior to the clavicle towards the lateral part. And as I place the probe this way, the first thing that hits out at you there are a pulsatile vessel, which is the axillary artery. And medial to that, you see the axillary vein, which you can also compress with the pressure of the probe. And when I tilt the probe inwards, you can see the pleura over there. So that is how close the pleura is to the great vessels in that area. So I'm just moving the probe superiorly now. So there you see the shadow thrown by the clavicle, that dark area there. And then medially is the subclavius muscle, where the arrow is going. Now, on top would be the pectoralis major. And as I move my probe inwards in this manner, you will see the pectoralis minor come into view. That is the pectoralis minor. And if you just move the probe a little more, you see a tiny pulsatile artery in the plane between the pec major and the pec minor. That is the lateral pectoral branch of the thoracoacromial artery. In the vicinity of this particular artery will lie your lateral pectoral nerve, and also close by will lie the medial pectoral nerve. And when you put your needle in this particular plane and inject about 10 mils of local anesthetic, that becomes the PEX1 block, which is useful when you do subpectoral prosthesis when you are doing an augmentation mammoplasty. But anyway, we are moving away from there, and we move to the point of interest, which is the infraclavicular brachial plexus, at which place the elements of the brachial plexus have reorganized themselves into 3 cords. You have the lateral cord, you have the posterior cord, and you have the medial cord, so named because of their relationship to the axillary artery. So I'll request my colleague here to point out at the lateral cord, which is just lateral to the axillary artery there. The posterior cord usually lies posterior to the axillary artery, and when I just move the probe a bit and release the pressure there, you see the medial cord lying in between the axillary artery and the axillary vein. So I just hold my probe in this position. I'm going to use a 50 mm Stimuplex needle, and I will be going in plane.
Dr. Gopal, do you prefer echogenic needles?
Yes, if I could afford them all the time, I would. But echogenic needles are a bit more expensive. But if you are going to do ultrasound guided blocks, echogenic needles definitely would make the practice of blocks so much safer and easier. So I'm putting the needle there in plane.
Can you show the, the gap, distance between, can you focus on the distance between the probe and the needle?
Yes. There's hardly any distance there.
Okay.
Can you see that?
Yeah, yes, yeah.
Okay. You can see the needle there. It is just beginning to approach the lateral cord, right? I'm just at the lateral cord. Can you see that, the movement?
Yeah, yes, we can. We can see the needle also.
Yes. Now I'm just going to ask my colleague to inject about 6 to 7 mils of local anesthetic at the level of the lateral cord. Please aspirate. It's negative. And as the injection is made, you can see the lateral cord, it gets very well delineated. Some more please. Can you see the lateral cord getting pushed down? And it's nicely surrounded by the local anesthetic now. Can you see that, Bala?
Ah, perfect. It looks very well.
Okay. I'll just stop here, and I'll now advance my needle towards the posterior cord now. Yeah, just a second. Okay, I think I'm at the posterior cord. I'll request my colleague to inject a little more. Please inject some more. Can you see the posterior cord being beautifully delineated now? It's being separated from the plexus, right? Now you can see the lateral cord and the posterior cord both floating in the local anesthetic. Yeah. How much have you injected so far? Okay, take 10 more. Now, having injected around the posterior cord, you can see my needle. It's actually abutting the posterior cord there, right? Now, I'm just withdrawing the needle, and I will try to target the medial cord, which is a little more technically challenging.
Do you think it will be easier for the beginners to do the medial cord by an out-of-plane technique?
Yes.
Would you use a hydrodissection there normally, or?
Yeah, you could actually, definitely yes. Can you just make an injection? Yeah, aspirate and make an injection. Yeah, good.
Yeah, that's nice.
Can you see the drug going around the medial cord also now?
Yeah. But we are not able to delineate the medial cord.
See that? It is being pushed down now.
Yeah, okay.
Yes?
Yes.
Can you see the medial cord clearly delineated now?
Yeah, yes.
Please.
Yeah.
Okay. Yeah. So I'm just withdrawing the needle under vision. See, that is the lateral cord there. Yes?
Yeah.
My needle is next to the lateral cord. That is the posterior cord there. And you saw the medial cord being pushed down now. Can you please point out the medial cord with the cursor? Just, yes, that's the medial cord over there. Okay, Bala, with this we have completed the
since it's a general anesthetic, can you just go to the out of plane and come in and show the medial cord with the out of plane technique?
Sure, I'll try to do that.
Because we need to learn the out of plane technique also sometimes, because the one which was done, because you need to pass the needle between the pectoralis minor and the artery, and when you go there, sometimes you might injure the vessel. So
I'm going out of plane now.
Yeah, sure. So here, I want you to appreciate the difference between the two. You will see the tissue movement.
That's okay, yeah, take it off.
There is a scout scan to see the vessels are there on the path. So now you see the tissue movement here. It's coming here. See, that is the tip of the needle. So even in out of plane, now it's pierced the pectoralis major, entering into the pectoralis minor. Yeah, it's...
Okay, now inject a bit.
So he's producing a hydrodissection to make sure that...
see that? See the drug now pushing the medial cord down?
Yeah, perfect. Yeah, excellent.
Yeah, thank you. That's enough. That's enough. Yeah,
excellent. Lovely demonstration, Dr. Gopal. Thank you very much.
Yeah, thank you, Bala.
Can you hear the applause? Very good. Excellent.
Thank you.
So next we, did you see the difference between the in plane and out of plane? And you saw the out of plane. Even in out of plane, if you have a good control, if you see the tissue movement, you will never injure the nerve structures. You have to go very slowly. Were you all able to appreciate the movement of the tissues and the tip of the needle in the out of plane technique also? Yes?
Yes.
Okay. It's very interactive, and if you want to stop and if you want to ask as many questions, any doubts that are occurring, you're most welcome to do so.
Sir?
Yes?
Sir, can I ask you one question?
Yeah, please ask. Dr. Gopal, there is a question for you.
Okay.
Sir, in this 13-year-old child, would you put clonidine into the local anesthetic?
Adjuvant, role of any adjuvants for your local anesthetics?
I personally do not use any adjuvants. I mean, you can use clonidine, you can use dexmedetomidine.
Dexamethasone.
People have used steroids in the form of dexamethasone, but all of these have not been actually approved by the FDA for use as perineural adjuvants. And since in this particular case, I was doing the block only for intraoperative and postoperative analgesia, I did not actually see the need for an adjuvant. And this block will give him excellent analgesia for about 16 to 18 hours, which is pretty good, by which time you can actually switch him on to oral analgesics for his pain control. So I personally do not believe in adjuvants.
So what was the total dose that you gave?
I injected about 16 ml totally of 0.25% bupivacaine. And subsequently, when Dr. Bala requested me to do the out-of-plane approach, I put in another 4 ml. So that is a total of 20 ml of 0.25% bupivacaine. This guy's body weight is about 35 kilos.
Thank you.
Thank you very much, Dr. TVS Gopal.
Thank you, Bala.
Yeah, there's another question.
Yes.
If this patient is a conscious adult, does he require sedation before this block?
Well, yes. I mean, you have different types of patients. I mean, some patients do cooperate very well when you explain the procedure to them. The most important part of doing a block is to take the patient into confidence and tell the patient about the procedure, because that is when you get them to cooperate very well. If I do see a very cooperative patient, I do not sedate them. What I do is just make sure I give in some local anesthetic before I put in my block needle, and then I proceed to do the block. But if I do have a patient who is quite anxious, then I would sedate them. My protocol would be to give about 25 or 30 mics of fentanyl, about 1 milligram of midazolam, and then I leave them on an infusion with dexmedetomidine. Dexmedetomidine has made the practice of blocks very comfortable. We give them 1 mic per kg as a loading dose over 10 minutes, and then anywhere between 0.3 to 0.7 mics per kg per hour as an infusion thereafter. They are pretty well sedated, and they do cooperate with blocks even if they are anxious when you give them Dexmed.
Thank you very much, Dr. Gopal. We go on to the next block.